Now I call upon Dr. Sandhya, Senior Cataract Surgeon, Giridhara Institute, to talk about posterior capsule issues in patients who are 6'6" and 6 unhappy.
Good afternoon. This 70-year-old gentleman underwent phaco with foldable intraocular lens implantation, and his visual acuity after cataract surgery was 6'6" and 6. But he complained of tailing of light and also linear glare while driving at night. So IOL was stable and anterior chamber was quiet, but dilated examination showed this linear capsular fold here, and this was producing this symptom, and this patient underwent YAG capsulotomy and he was symptom free. Now this patient had normal vision after cataract surgery, but he complained of glare and increased light sensitivity, especially at night. So he told he had the same symptoms before surgery, and it didn't, I could not remove it with the surgery. So he was not relieved. So this was, this early posterior capsule opacification was there, and this patient had, multifocal IOL was there. So this early PCO can produce glare and increase light sensitivity, and it can be more troublesome for patients with multifocal intraocular lens. And this patient had underwent uneventful phaco 1 year back and came with decreased vision. His visual acuity was 6/9 parts N8. And you can see this clouding within the pupillary area. And on slit examination, we could see this turbid, cloudy fluid behind the intraocular lens. And actually, if you see carefully, here you can see the residual lens epithelial cells that have proliferated. And this underwent metaplastic changes and then produced extracellular matrix, and that collected behind the IOL. So since the rhexis was overlapping and it was stuck onto the optic of the IOL, this couldn't escape. So this ASOCT showed accumulation of this hyperreflective fluid behind the IOL, and it was causing distension of the posterior capsule. So this was capsular bag distension syndrome, and the capsulotomy was done to release this fluid into the vitreous, and afterwards that area became clear and visual acuity improved. So this patient had undergone cataract surgery, and before surgery he had a pinpoint pupil, and phaco was done with the help of iris hooks. During surgery there was significant pigment release, and after the surgery there was exaggeration of anterior chamber reaction, and about 2 years later this patient came with decreased vision. So we couldn't see this tough membrane in the pupillary area. So that was almost adherent to the lens. So a nick was made with a Sinski hook, and this was not coming with microrhexis forceps. So a microrhexis scissors was used to cut this membrane, and the visual axis was cleared. But this was done under a cover of oral steroids because the patient had increased reaction after surgery. So, but still, his visual acuity improved reasonably, but then he still had symptoms like scattering of light because pigments were deposited on the intraocular lens. And this patient had normal vision after surgery, but then his quality of vision was poor because of the vitreous in front of the lens. So how can we prevent this PCO and other related issues? So the rhexis should overlap the IOL optic uniformly so that the optic is sequestered from the inflammatory effects of the mediators within the anterior chamber. And then you should do a good hydrodissection to break all the capsulocortical adhesions, and also do a good complete removal of the cortex. And then in the back placement and this square edge lenses will prevent migration of the lens epithelial cells from the equator to the posterior pole. And you can also polish the capsule to remove the residual cells which undergo this proliferation metaplasia and produce PCO and other related issues. Now coming to capsular phimosis. In this case, there is excessive contraction and fibrosis of the anterior rhexis margin, which can obstruct the visual axis or can produce secondary effect like IOL tilt, decentration, etc. Because of zonal laxity and weakness. So the lens cells, there is metaplasia and fibrosis of the lens epithelial cells, resulting in purstring contraction of the anterior capsular opening, and sometimes the opening can completely close also. So this is exaggerated by the imbalance between the centrifugal forces on the sonules and the centripetal forces that act on the capsular rhexis perimeter. So sonular weakness, pseudoexfoliation, high myopia are all risk factors for capsular phimosis. A large capsular rhexis and meticulous lens epithelial cleanup at the time of phaco can reduce its incidence. And if there is severe sonule weakness, you can do a can opener capsulotomy instead of capsular rhexis. Now this patient had pseudoexfoliation and also the pupil was not dilating well. So as you can see here during the rhexis, the entire lens was moving, and also the rhexis there was great difficulty in continuing. So during hydrodissection, as you can see here, the anterior rhexis margin was coming forward. That again is a sign of sonule weakness. You can see the folds on the posterior capsule, and there was the entire bag was shaking during the aspiration of the epinucleus. So these are all signs of severe sonule weakness. And in this patient, a CTR was placed and a lens was placed in the bag. Actually, ideally, a capsule tension segment also, we could have placed a capsule tension segment to stabilize this bag. Why I showed this case is because it is important to understand the signs of sonule weakness so that we can take necessary intraoperative precautions to prevent the occurrence of capsule phimosis and decentration. Now in this case, the patient had sonule weakness and a CTR was inserted in the capsular bag and a 3-piece lens was placed on the rhexis margin in the sulcus, and then the IOL was captured. So this CTR causes equatorial expansion of the capsular bag and uniformly support the sonules, and the two haptics in the sulcus, they give extra anchorage to the lens. So the chance of phimosis and decentration are less. This patient had severe sonule weakness. A CTR was inserted before phacoemulsification to give equatorial support, and a capsule hooks were also used to give anteroposterior support, and multiple radial cuts were made on the rhexis margin so that the centripetal forces that act on the IOL is less, so that there is less contracture and decentration of the lens. So something like a small can opener capsulotomy. So this patient had a mature intumescent lens, and rhexis was done in 2 stages. After IOL implantation, there was asymmetry on the rhexis, and so this rhexis was secondarily enlarged so that there is some symmetry on the forces on the sonules and the capsule. So in this case, this video was given by Dr. John, and so posterior capsulotomy was done, and again multiple radial cuts, as you can see here. Here multiple radial cuts were made on the rhexis margin so that the contractual forces will reduce and there won't be any progression of contraction. And also if there is severe phimosis, you can decentration of the lens, and you can remove it and can place any type of secondary IOL. So to summarize, suboptimal visual outcome in spite of normal visual acuity is not uncommon due to various capsular issues, and it is important to identify them and treat accordingly. Thank you.
Thank you, Dr. Sandhya. Nice presentation. One quick question. Suppose you see a little bit of pearl equatorial cells. Do you feel that is more important to attack those equatorial cells and less important to look at little lens fibers that or fibrosis that may be on the posterior capsule?
Lens epithelial cells are more dangerous. That's what I feel. And then if fibrosis or plaque is there, it is slightly dangerous to polish also that area, because the area adjacent to it will be thin. And if the lens epithelial cells, you have to remove it completely.
So yeah, I think I agree with that, because lens epithelial cells is what causes a pearl PCO, and that is what causes scatter of light and visual disturbances. The fibrous portion looks terrible maybe on slit lamp examination to us, but actually may be causing a little bit of loss of contrast at the most, and we can afford to leave it and YAG it later if required. Thank you.
Thank you, sir.